This is the first lecture on our cardiovascular unit, so you've gotten through fluids and electrolytes, and we're ready to get into heart and blood vessel diseases. So we start with disorders of blood flow and blood pressure. Couple things just to review. You should have done the, if you haven't done, please do the cardiovascular review lesson. That review lesson focuses primarily on heart structures and heart function, not so much on the blood vessels. That's what we're going to be working on here first, but we'll get into cardiovascular with Chapter 19. So be sure you know blood flow through the heart and coronary circulation. By that I'm talking about the blood flow coming off the left and right coronary artery, their main branches, the main veins that the deoxygenated blood flows into at the heart, flowing into the coronary sinus. And when you're doing blood flow through the heart, be certain that you're including with the superior and inferior vena cava, returning blood to the right atrium, that you also include the coronary sinus, delivering its blood from the heart muscle itself back into the right atrium to continue on the blood flow through the right side of the heart to the lungs, and then of course back from the lungs through the pulmonary veins to the left side and out to body tissues. The lesson will take you through all of that. You should also be very familiar with the conduction system of the heart. That's the SA node, internodal pathway AV node, bundle of His, and so forth. So if you're not familiar with the conduction system of the heart, you don't remember those autorhythmic fibers and that pacemaker potential, all of that, please go back to your A&P book and review that. Cardiac cycle refers to the systole and diastole of both the atria and the ventricles. And then some very important concepts: preload, afterload, contractility, stroke volume, EDV and diastolic volume, ESV and systolic volume, cardiac output. Sorry, I don't know why the PowerPoint does that every single time. The EDV is end diastolic volume and end systolic volume. Those two values, the difference between EDV minus ESV is going to give you stroke volume. Cardiac output is a function of the heart rate times the stroke volume, and then ejection fraction is that percentage of the blood ejected from the heart with each contraction. We'll also be looking at stroke with this unit, so you need to understand blood flow through the brain. So if you've forgotten your cerebral arterial circle or circle of Willis, please be sure to take a look at that. Chapter 37 does have a nice picture of the cerebral arterial circle and its associated blood vessels, arteries, so take a look at that. We're going to look at structures of blood vessels and regulation of heart rate and blood pressure here in this chapter that we're moving forward. So this is stuff that comes from your cardiovascular unit in A&P 2. If you're weak on this, this is some of the main things that you want to be reviewing. All right, taking a look at blood vessels, we're going to start with disorders of blood vessels. It's expected that you would be familiar with the layers of the blood vessels. I've got a picture here. The outer layer, the tunica externa, is connective tissue, contains the vasa vasorum. That's the blood vessels to the vessel itself. It's kind of the same way, best way I can say what vasa vasorum is. It's kind of, think of an analogy. You have coronary arteries and veins that provide the nutrients to the heart muscle itself. Well, the vasa vasorum are the arteries and veins that provide nutrients, oxygen to the blood vessel itself. So the coronary arteries to the heart muscle, vasa vasorum to the blood vessel. Now, if we get to small capillaries, there's no vasa vasorum, but when you start thinking about the aorta and the large muscular arteries, brachial arteries and femoral arteries, those that you would have learned the names of in A&P 2, all of those need to have their own supply of nutrients, and it gets that through what we call the vasa vasorum, and it's found in the tunica externa, the outer layer. Tunica media is your smooth muscle layer. Just a reminder, smooth muscle of all blood vessels receives its nervous innervation from the sympathetic nervous system, not the parasympathetic, the sympathetic. So it's only sympathetic that can cause the vasoconstriction and vasodilation. So many hormones and things can do that, but in terms of nervous innervation, it's sympathetic. And then the tunica interna or tunica intima is the innermost layer, and the innermost layer of the innermost layer is the endothelium, that inner lining that's continuous throughout all the blood vessels in the body, including the smallest capillaries, and it's the part that actually, or the layer that actually comes in contact with the blood. Again, that should be some review. Arterial sclerosis and atherosclerosis. Let me just define those two terms. The arterial sclerosis means hardening of the arteries and is a more general term for diseases in which the walls of arteries become thick and less elastic, so they lose their ability to stretch. That's arterial sclerosis. Atherosclerosis is the most common form of arterial sclerosis. It is the hardening that is related to the formation of fibrofatty lesions in the endothelium of our medium and large vessels. So I'll repeat that definition for you. Most common type of arterial sclerosis is atherosclerosis. So spelling's very similar, RT versus ATH. It is the hardening of the arteries that's related to the formation of fibrofatty lesions in the endothelium of medium and large arteries. Okay? Hyperlipidemia or hypercholesterolemia is simply high cholesterol. That's what we're really dealing with there. It really is simply an elevation of lipids or fats in the bloodstream. We're going to be looking at a couple of types of lipids. Cholesterol is the one we've talked about, or not talked about, you've probably heard about a lot. You talk about high cholesterol and taking medications to lower cholesterol and so forth. The phospholipids, you know, from the layers of the blood vessel, and then triglycerides are, we're going to look at them shortly. Triglycerides can be just as damaging and can be converted into cholesterol. So we're going to look at those. Those are the types of lipids that we're going to be dealing with in terms of hyperlipidemia if we have high concentrations of lipids within the blood. Okay, so within the lipids in the blood, they consist primarily, we are really dealing with cholesterol and triglycerides. They are insoluble, meaning they don't dissolve in plasma, and they have to be carried by transport proteins. Okay? Lipids, in order for them to travel throughout the blood, since think about what the nature is of our cell membranes, they're made of phospholipids, they're lipid-loving. Lipids can diffuse in and out of blood vessels and diffuse into cells throughout the body quite easily based on the structure of things. They're, again, that water-loving that lipid-loving plasma membrane allows lipids to fairly easily diffuse across. Therefore, in order to get lipids where we want them to be, this is actually true. Think about of your lipid-soluble hormones. They too require a carrier. They can't just be allowed to just freely flow through the blood. They'll diffuse out too quickly and not get to their target. So lipid-soluble hormones require protein carriers, and lipids in general in the blood require carriers to be transported. Those carriers are called lipoproteins. So lipoproteins are what carry the lipids in the blood. They're the transporters of the lipids. Okay? So lipoproteins are made in either the liver or the small intestine, and we're going to be looking at several types of them. So that's what they're doing. They're carrying the lipids produced. These lipoproteins are produced either in the liver or the small intestines. Lipoproteins consist of a complex of lipids and specific proteins, and those specific proteins are called apoproteins. I do want you to know that term, apoproteins. I want you to recognize that they're a component of lipoproteins. All lipoproteins have apoproteins. This is a picture actually from your book showing you some of these apoproteins. Okay? They add stability to the molecule, and they are involved in activating enzymes for lipoprotein metabolism. In other words, the ability to break down and make use of the lipids that are contained within that protein. Okay? Also, the main reason I want you to know this term, apoproteins, is because it has been determined, and there's continual research, even beyond the date of this textbook, there's new research out there supporting this, that genetic defects in apoproteins are thought to be involved in hyperlipidemia and rapidly developing atherosclerosis. Let me say that again and then explain that. Genetic defects in apoproteins are thought to be involved
in development of hyperlipidemia and rapidly developing atherosclerosis. More specifically, you've got somebody who looks like they're fit and they have high cholesterol, and you wonder why in the world is somebody who takes care of themselves, really seems to eat well, exercises, and they have high cholesterol. The link apparently is coming out with what is the genetic mutations that are occurring in these apoproteins. So if these apoproteins aren't properly configured, they can lead to rapidly developing atherosclerosis and hyperlipidemia, or high cholesterol, high lipid levels. So that's why I want you to really know them. Don't worry about so much with lipoprotein metabolism. I want you to know that an apoprotein is a component of a lipoprotein, and that when there are genetic defects in the apoprotein, it seems to be linked to genetic high cholesterol issues, things that you wouldn't normally expect to be occurring and that are occurring. Okay? All right. Types of the transport or lipoproteins. Okay, there are 5 types of transport proteins, 4 of which you are responsible for and must know. And the proteins, or the lipoproteins, are classified based upon their density or protein content. Okay, 5 total, 4 of which you must know. So the 4 that you need to know are listed here. Chylomicrons, formed from fats in the foods that you eat. They're absorbed in the small intestine. So the chylomicrons, sorry, my headphones are falling off, are formed in the small intestine. So it has to do with the food that you intake, formed in the small intestine. They contain mostly triglycerides. They transport fats to muscle and adipose cells. This is what remember, this is a transport protein. So what's in it? Primarily triglycerides. Okay, that's most of what makes up a chylomicron. Okay, it's mostly triglycerides. It transports these fats, these lipids, to muscle and adipose cells. So they're transported, that's where they're taking them. Okay, we've got some values here. Below 150 is the desirable number. High is considered above 200. Okay, VLDLs stand for very low density lipoproteins. VLDLs, remember we're talking about the carrier protein. They are made or synthesized in the liver, and they contain, and you can see right here in the picture, mostly triglycerides with some cholesterol. Mostly triglycerides, some cholesterol. They transport the triglycerides from the liver to the adipose cells, to the fat cells. That's what they do. They transport triglycerides from the liver to the adipose cells. And then, again, their values, their levels, are the same as the chylomicrons. Okay? Now it gets a little tricky. LDLs are low-density lipoproteins. Low-density lipoproteins have, look at what, from the picture you can see, very small amount of triglycerides and quite a bit of cholesterol. Now, and there's proteins present in all of these. Understand that's important. It's part of what they are. But what we really are caring about primarily is how many types of lipids, what is that percentage of lipids, and where are they going, what are they doing with it? Okay? So, this is how the LDL is formed. The VLDLs, they have delivered their triglycerides to the adipose cells. That's what we just said they did. So the triglycerides are delivered to the adipose cells. When the VLDLs delivered their triglycerides, they gave up most of it. Okay? So then the LDL actually consists only of the cholesterol that was left. So a LDL is actually a VLDL after it's given up its triglyceride. It is not a new substance. It is simply what we have as we go from step 1 VLDLs to step 2 LDLs. So technically an LDL is also made in the liver because it is a VLDL, which is where they were made. So VLDLs pick up all these triglycerides and cholesterol in the liver. They go to adipose cells. They deliver it. Okay? What's left is a little bit of triglyceride, and then it's mostly, because remember, this is a percentage. It's not a volume, it's a percentage. The VLDLs were only 10% cholesterol. Well, now what's left is mostly cholesterol and a little bit of triglycerides. So now LDLs are primarily cholesterol, over 50% cholesterol. And then the LDLs, they don't take that cholesterol to adipose cells where we could hold on to them and keep them there. They will deliver it to various cells in the body. They'll deposit it wherever they can. And this is where the LDLs become problematic, because they can deliver it to blood vessel walls. Anywhere there's a little bit of damage, they kind of get hung up there, and they can deposit their cholesterol there. And so various cells, particularly blood vessels throughout the body, can then be targets for where LDL can deposit or give up its cholesterol. Right? So LDL levels below 100 is ideal, high is above 160. You will be responsible for these numbers, so you need to know these. Okay? And then the HDLs, high-density lipoproteins. If you take a look at it from what you've got here, you've got 5% triglycerides, 20% cholesterol, and 50% protein. Now, these here are predominantly protein. They are formed in both the liver and the small intestine. So this is not a conversion. This is its own structure. HDLs formed in the liver and the small intestine. They consist of some cholesterol and a little bit of triglycerides, and they are responsible for reverse transport of cholesterol. Listen carefully. That means that HDLs are thought to take cholesterol from the tissues where the LDLs deposited them, pick it up from wherever it was deposited, and bring it back to the liver. So it goes in reverse transport of cholesterol. We're going the opposite direction. Instead of depositing it all over the place, we're picking it up, we're bringing it back to the liver, and then it's thought that the return cholesterol is then processed and sent through the GI tract for excretion as waste. It really comes out with the bile and becomes a waste product. So real important to understand that. Our total cholesterol below 200 is desirable, high is above 240. So again, knowing those numbers is important. Levels of the bad transport proteins, particularly the VLDLs and the LDLs, can be decreased with exercise. Likewise, the HDLs can be increased with regular exercise. And there is the statement in the book about moderate alcohol consumption seems to be linked to higher HDLs. I'd be very cautious with that statement. There's a lot of research out there saying, I'm not saying, avoid alcohol, it's all bad. I'm not saying have a drink every night because that's good. I'm saying, caution and moderation by far needs to be respected with alcohol consumption. I think if you're exercising, that's the much better way to increase your HDLs and reduce your LDLs and VLDLs. Okay? And I didn't mention it, but it is on here. The desired level for the HDLs is between 40 and 60. That's probably your desired level. A little higher is necessarily always better. Okay? All right. Hypercholesterolemia manifestations. In other words, high cholesterol manifestations. Okay? Now, this is really high levels of cholesterol or triglycerides or both. These are the manifestations. And by the way, they can develop either, this condition can develop either as a primary problem, that is, it's simply genetic, like we mentioned before with the apoproteins, genetic levels of high amounts of cholesterol, or it can be some other disease process in which you don't excrete or get rid of lipids as necessary. There are disease processes, a lot of genetic disorders and things that go into metabolic problems that can be linked to high levels of cholesterol. But most of the high cholesterol that you'll come in contact with is really secondary. In other words, something else is causing the problem. Primarily, it's a lifestyle issue, or it's linked. This is a real big problem for people who suffer from diabetes mellitus. And so because they are processing high levels of lipids instead of glucose due to the lack of insulin, you can see high cholesterol issues for people suffering from diabetes mellitus, and we'll look at that more closely at the end of the course when we look at diabetes. So the vascular disease is one of the biggest problems with high cholesterol. Includes CAD is coronary artery disease, so you have blockages in your coronary arteries. PAD is peripheral arterial disease. That is plaque buildup, cholesterol buildup in the arteries outside the heart in other areas of the body. So clearly, and we're going to look at we're going to look at both coronary artery disease and peripheral arterial disease here in the next couple of chapters that we're looking at. Xanthomas, that is a good word for you to know. It's almost always on the exam somewhere. Xanthomas are benign fatty tumors of yellowish plaque or nodules that develop in the subcutaneous layer of the skin, just below the skin, right, generally around tendons. They like to accumulate there. And I've got 4 pictures showing the accumulations of xanthomas. Okay, so it's a little hard to make out the ones that are here around the eye. That's probably not the best picture of the xanthomas. You can't really make it out, but certainly the other ones are very obvious. If cholesterol levels get really high, it is actually, I've heard clinicians tell me that they've seen as extremely high levels of lipids can actually give a milky appearance to blood plasma. Blood is drawn and then the blood spun so that you get the red blood cells and the solutes. They spin out and you're left with the blood plasma. It should be more or less clear, maybe a pale yellow color. With someone who has high cholesterol, hypercholesterolemia, you will see their plasma actually look milky due to the high levels of lipids in their plasma. Extremely high levels can cause the paresthesias. You know that term from our electrolytes chapter. Dyspnea is painful shortness of breath, and it can affect CNS functions in the brain and lead to confusion. The lipids literally block nerve transmission. All right. Risk factors for the development of atherosclerosis. Remember, atherosclerosis, just to remind you, the definition is the formation of fibrofatty lesions. It's going to be in the medium and large size arteries, and it forms in that tunica intima, that innermost layer. Okay? This chart 18.1 gives you risk factors. I think it's also in your book on page 412. Notice that we have some non-modifiable risk factors. We haven't used the term risk factors before. This is kind of opposite of manifestations. These are things that can lead to be possible causes or links to it. It's not direct causes, but things that can link. We looked a lot at kidney failure or liver failure or lack of albumin can lead to edema. That's a direct cause. We know why ascites forms from the lack of albumin, causing the edema to form in the third space. That's a direct cause. With atherosclerosis, it's not as clear-cut an issue, and there are usually multiple things going on that can lead to the cause. Okay, for instance, almost everybody who has, just to kind of clarify this risk factors thing, almost everybody who winds up with liver disease and stops producing albumin is going to wind up with ascites. That's just trademark. It's really not, geez, you have liver disease and no edema. That's just not going to occur. That we know that's going to happen. However, you can find somebody who does, is obese and does smoke and maybe even has hypertension and is older and is male and they don't have atherosclerosis. So it's not an all-encompassing kind of thing. But what we do know is that as you get older, if you are male, at least when looking at males versus females prior to menopause, after menopause, females really do fall into the same risk factor. If you have some genetic disorders of lipid metabolism that's something you cannot change, family history of problems, the odds are those things make you much more likely to have atherosclerosis development. That's not a guarantee, but it's much more likely. And then we know that these are what they call, and I'll take issue with that, potentially modifiable. I'd say they are modifiable. I know it's not easy, but people can stop smoking. People do stop smoking every day. So it's a question of whether or not you can find the means to do that. But certainly you can stop. If cigarettes were suddenly gone, I guess you'd stop smoking. So that makes it quite modifiable. So I do want to say that I got a little issue with that term potential. Certainly you can stop that. Obesity is a little bit tougher. Certainly lifestyle changes, diet changes allow you to modify that, but there are genetic links to some issues of obesity that make it difficult. Not everybody's going to be a size 4, for females that is, and size 28 waist in a male. There's going to be some genetic linkages about how your body shape is. Hypertension, we're going to talk about that in the next lecture. I think it's the next one. With hypertension, sometimes people have high blood pressure and they're very fit. They look great, and yet they still suffer from high blood pressure. That may be something you cannot modify without medication. Some diabetes mellitus, there is certainly, especially type 1, that is a genetic and autoimmune issue and cannot necessarily be prevented, although type 2 is certainly linked to lifestyle. Other kinds of things that can cause problems, any kind of increased lipoprotein levels, other issues, things not so much to worry about. Think about the ones that you're familiar with. I'm not trying to get into a lot of detailed terminology here. See my next. Before I go to that one, a couple other things in terms of the development of atherosclerosis and the different vessels. I want to make sure. I'm going to jump ahead for a second here. That's the process. Okay, I'm on track. All right, I am going to jump to here and the lesions, and then I'll go to the individual blood vessels. I do have that on a subsequent slide. All right, so in terms of lesions or damage that can occur with lipids, we're going to break those into 3 types. All right, the first one's fatty streaks. Now, fatty streaks are they're just what they sound like. They're streaks of fat that can be seen lining in certain areas within blood vessels. There are several theories on how significant fatty streaks are. Do they really develop into lesions and problems? There's some question about that. There is definitely fatty streaks that develop within the first decade of life. So I can look at my 7-year-old daughter's inside her blood vessels and I would find some fatty streaks in there. But I assure you, she's a tiny little thing and she doesn't look like somebody who would have high cholesterol at all. It's certainly not linked to lifestyle, and certainly there's no reason to think that those fatty streaks are in any way damaging. Okay? So, however, there is thought that is areas just within blood vessels that may in fact be future sites where plaque formation could occur, and that the fatty streaks are simply part of the development and lifestyle or not lifestyle, but part of the development of those blood vessels. Young children, particularly infants, need higher levels of fat for brain development. We mustn't think all lipids are bad. There are certainly needs for them in the body, and so they may form in vessels and they may come and go. No one really has any good data on, no one's looking inside people's blood vessels over the course of time to determine if in fact they're always in the same place and are in fact really linked to damage. Nonetheless, fatty streaks that form later in life in adults tend to be thought as the beginnings of atherosclerosis development. So there's some that are there when they're younger. They may continue there and be vulnerable sites in the future. They may not. We don't know. But what we do know is that those that start developing later in life, they are linked to additional further problems. Now, a fibrous atheromatosis plaque is the accumulation of lipids, mainly cholesterol, with proliferation, that means more growth, of smooth muscle cells and formation of scar tissue. Okay? So, a fibrous atheromatous, I'm sorry, I think I said that wrong the first time. Fibrous atheromatous plaque is an accumulation of lipids, proliferation of smooth muscle, and formation of scar tissue. That's plaque buildup as we know it to be. Okay, so when someone says they have plaque buildup, that's what we're talking about. We're going to look at that process for how that forms in just a minute, but that's the problem. A complicated lesion is where that fibrous atheromatous plaque, where that formed, it actually forms an ulceration, a tear in the vessel. That means there's some bleeding of the vessel, blood will leak in, and additional scar tissue forms. So 3 types of lesions or potential damage to the blood vessel: fatty streak, which in young people apparently is not a problem, but as you develop older, maybe an area of vulnerability where more will develop. Fibrous atheromatous plaque is the actual plaque buildup that we see when we talk about plaque and blood vessels, things starting to block blood vessels. That's what we're talking about there. And then the complicated lesion is where that plaque buildup was. And here, my pictures show plaque buildup here, and this is the deformation of a complicated lesion, where you've got proliferation of smooth muscle, and you've got damage forming in the vessel where bleeding can occur. All right, so the development of atherosclerosis is a 4-step process. Now, these are the pictures straight from your book, so please take a look at, there's a 2-page spread in your book on pages 414 and 415 that explain this process. I'm going to go through it kind of quickly here, but then go back through it. You'll be required to know this 4-step process, so the pictures help you to see what's going on here. So, in step 1, what you have is endothelial cell injury. You'll have, this is really where the fatty streak, and we're starting to have the formation of the fibrous atheromatous plaque. So, damage can be caused by hypertension, smoking, high levels of LDL starting to accumulate, any of those things. You have some damage to the endothelium. Monocytes and platelets begin to adhere to the site of injury. Notice it's inflammation that starts to happen. So you have injury and there's inflammation that starts to happen here. So monocytes, platelets begin to adhere to the site of injury, and the endothelial cells themselves stop making anti-clotting and vasodilation substances. So they stop doing what they're supposed to do. Endothelial cells make nitric oxide for vasodilation. They stop producing that. This is going to increase tendencies for clots, and there'll be more vasoconstriction, which can raise blood pressure and make the problem worse. In step 2, you have further migration of inflammatory cells. So now the inflammatory process is getting greater. Chemicals are released by the damaged cells. They bind to the monocytes, which will form macrophages and start to engulf the LDLs that are there. So you have the picture here showing the migration of these cells. These are monocytes. They're turning into macrophages, and they're engulfing, taking up the LDLs that are accumulating there. Okay? This is good in that the LDLs are removed from circulation. So that's a good thing. Inflammation's a good thing. It starts doing, we've got the accumulation of LDLs there. We want to get rid of them, so it starts engulfing them. We see that as a good thing. The problem is they don't engulf them and dispose of them and get rid of them. They start to get accumulated there. Can't really break them down, and there they sit, accumulating in the wall of the blood vessel. Step 3, we've got lipid accumulation and smooth muscle cell proliferation. Now we're really getting to our fibrous atheromatous. Atheromatous. I keep saying that backwards. I'm sorry. We're going to have another term that looks very similar in another lecture. Atheromatous plaque. Okay? So, at this stage, in stage 3, this is where we're really getting that huge buildup. Notice we've seen very little change in the size of the lumen here, but now look at what's happening to the size of the lumen and even the smooth muscles that make up the blood vessel wall. The macrophages continue to engulf LDLs and cholesterol, and they form their big, huge cells now called foam cells. So in step 3, we now have foam cell development. These foam cells release growth factors, and that causes the proliferation of the smooth muscle cells. So proliferation, remember, means to divide or make more of. So suddenly, smooth muscle that shouldn't be dividing, it doesn't normally make more of, it starts dividing and making more. So you have the proliferation of smooth muscle cells. Now you see what's happening with the size of the lumen. This is going to lead to ischemia or ischemia, and it may not be until this point that the patient starts to feel a problem. So if we're at a coronary artery where this is happening, suddenly we're not having enough blood flow to the cardiac muscle tissue, and we're going to start to have some angina or chest pain because it's going to feel like we're not meeting the needs of the heart. And then step 4 takes us to the full formation of the plaque structure and a complicated lesion. Remember the third kind of lesion, the complicated lesion. Collagen is involved here. Now, collagen is a strong and very abundant protein in the body. And so collagen comes to the area and forms a cap to wall off the area, trying to deal with the problem. But by doing so, by forming this fibrous cap with this collagen in it, it actually further reduces the size of the lumen. So we're trying to solve a problem. We've got this complicated lesion, tissue starting to tear, bleeding may start to occur as blood starts going. Remember, blood's supposed to be flowing through this vessel, and now it starts leaking down below the endothelium. It's becoming a real problem. We'll build a cap over it to try and contain or wall it off, but now the lumen's even smaller. At this point, if you don't make some radical lifestyle changes, the damage may become permanent. It won't be able to be fixed, and we have significant scarring going on here. One term I'll throw out here that hopefully you've heard of before is collateral circulation. Collateral circulation is linked to also the term angiogenesis. Angiogenesis is the term for growing of new blood vessels. Another term, anastomosis. Hopefully you've heard all these terms before. They should have been A&P2 terms. Angiogenesis is the growth of new vessels. Anastomosis is the connections that can be made between blood vessels. And collateral circulation is the new pathway that's developed due to angiogenesis and anastomosis. As we start seeing this lack of blood flow to an area, the body starts growing new blood vessels that start back over here and link around to come around to the other area and cut out. If this were a heart vessel, instead of flowing through here, we'll find another pathway and flow around it. Now, it takes years for that to happen, and likewise it takes years for this plaque formation to occur. So it is possible that as the plaque buildup is going, depending upon the overall condition of the person and the ability to grow these new vessels, new pathways may be grown to help get around that and get more blood delivery. So that can help attempt to reroute the blood and solve the problem. Now, with our complicated lesion here, we actually get platelet plugs. The platelets come in to try and gather in this area and prevent additional blood loss. But we can actually get to the point where we totally occlude, meaning we block off. Occlude, O-C-C-L-U-D-E, to occlude a vessel is to totally block it off. So with the platelets, with the fibrous cap formation, this is where we can cause cardiac arrest because the tissues will not get the blood at all, and the blood vessels will die, and we will have a myocardial infarction or cardiac arrest. They're two separate things, truly, but both of it can lead to the inability of the heart to pump effectively. Okay, just as a note for treatment for something like a complicated lesion, you can give antiplatelet medications such as aspirin. I think your book mentioned something called Plavix, which is a common antiplatelet or anti-clotting medication that can be given to help break away some of this or degrade some of this. Break away is an entirely different thing. If the cap should break off, you now have, instead of a clot or thrombus there blocking, you now have an embolism possible, and if that gets to the lungs, pulmonary embolism will kill you. If it goes to the brain, it'll lead to stroke. So this can break away, particularly if the blood pressure is high enough and it's pushing on it, and this cap can break off. All right, and finally on this lecture, manifestations of atherosclerosis. In all areas, you will see decreased tissue perfusion, perfusion, P-E-R-F-U-S-I-O-N, decreased tissue perfusion means lack of blood flow to an area. Ischemia would be another way of saying it, although ischemia tends to be in just one area and just like a constriction of the vessel. That's not quite the right word I want here. I like increased tissue perfusion. Less blood is getting to the target. That's what we're really saying here. There's increased resistance since the narrowing of the vessel, so that increases blood pressure. And edema can certainly be an issue as blood backs up behind it. The filtration pressure increases in the blood behind where the clot or where the plaque cap has formed, and that pressure behind it forces fluid out. So there can be behind the site of wherever the blockage is, you'll have increased edema. Now, there are some manifestations that are unique to these various areas. In the cerebral arteries, those are talking about carotid and vertebral arteries in the brain. In early stages, it leads to TIAs, which are transient ischemic attacks, and we'll look at those with stroke. And of course, further on, it can lead to cerebral vascular accidents or strokes. That's the same thing. In the coronary arteries, it'll lead to myocardial ischemia, which can lead to myocardial infarction. It'll cause conduction disturbances and angina pectoris, which is chest pain. In the abdominal aorta, it can lead to ischemic effects on the lower extremities, including gangrene of the toes, feet, formation of fusiform abdominal aneurysms, and that'll make sense when we talk about aneurysms, but for now, just make a note, fusiform abdominal aneurysms. Embolisms can form, as I mentioned earlier, if some of the stuff breaks off and goes into smaller arteries, so that's a real problem in the abdominal aorta. In the iliac and femoral arteries, and if you don't remember where the iliac arteries are, go back to your A&P book. We're getting out down into the pelvic region and down into the thighs and lower legs. There's something called intermittent claudication. This is a good term again, like paresthesia is a good definition term. Intermittent claudication is an aching, cramping, kind of tired and sometimes even burning pain in the legs that comes and goes. Intermittent meaning to come and go. Claudication is this cramping, aching pain. It typically occurs with walking, but goes away with rest. Right, so intermittent, we're going to use that term a couple of more times with other diseases linked to blood vessels. Intermittent claudication. Pain usually comes when you move and stops when you don't move. Here's the problem. If it hurts to move, you stop moving, and the problem gets worse because exercise can help solve the problem, but it can be very painful. In renal arteries, atherosclerosis leads to renal hypertension, which can lead to hematuria, which is blood in the urine, and proteinuria, which is protein in the urine. And in the mesenteric arteries, this is in the abdominal area, intestinal ischemia can lead to bowel perforation with peritonitis. Bowel perforation means tearing of bowel. The large intestines, the walls can tear, and peritonitis can mean anything. Itis is inflammation of the peritoneal. All right, that'll take you through atherosclerosis. The next lecture should pick up with arterial diseases in the extremities.